So first things first, the summit's called Re-Evolution Summit. So it has a redo and evolute in it. So make sure you all know that. I can't change.
I think you have to use one of these clickers.
Okay.
Do you have one?
Nope.
You can use the mouse.
Okay. All right, here are my disclosures. I'm an interventional cardiologist, which is the most important disclosure here in this room. All right, so TAVR in young patients. Why are we talking about TAVR in young patients? I mean, it's very clear, the cutoffs, you know, if somebody's very old, you want a TAVR, somebody's very young, you really want a surgery. So TAVR in young patients, typically it's by the ages between 60 and 75. But saying this, what's really important is when the life expectancy is really high, and we're talking about more than 20 years. So these are the current guidelines in the United States, where they talk about patients who are above 65. And if you follow that, it's really clear that they say it's a class 1 indication for surgical aortic valve replacement or for TAVI. And that's way different than the European guidelines, which we'll talk about a little bit later. Now, it's really important to note that age is not equal to surgical risk. We all have seen patients who are 60 years old, maybe they have a kidney transplant and now failed, they're on dialysis, they have so many other comorbidities, and then despite that they're 60 years of age, their inside body and internal body is probably 90 years old, and that's a total different population. So focusing on the outcomes and the difference between TAVI and SAVR is very important. So these are majority of the studies that have been done that are trials head-to-head between surgical aortic valve replacement and transcatheter aortic valve replacement. As you can see, they're pretty much comparable with non-inferiority between whether you go by the partner trials and by the SURTAVI and the Evolute low-risk trials here. Progressively, there are sort of non-inferior, at least in the short term and a little bit in intermediate term. But most recently, this is one of the most recent publication in 2025, which is the Partner 3 trial that is a 7-year data. And clearly you can see that in patients who underwent TAVI versus SAVR, the death from any cause, stroke and hospitalization, they're almost the same, right? 34.6% at 7 years versus 37.2%. They're non-inferior, and that goes for all-cause mortality. At some point, looking at things, there's a crossing at 3 years in the death from any cause, and looking at the rest of the data from stroke and rehospitalization, definitely surgery in the beginning had more strokes, but then later on sort of TAVI caught up. Now, on the other hand, the Evolute low-risk trial, which was also very recently published in 2026, and that's the 6-year follow-up, and they showed some 7-year data. So if you guys go back into 2019, then 3 years later in the publication of the 4-year Evolute, if you cut those and stop there, definitely TAVI had a big favorable outcomes. But once we see at 6 years, maybe those these lines cross, we still don't know because there are so many studies that have shown that a lot of things, when they cross, they can cross back. Look, for example, at the SHOCK trial, which was one of the trials that was negative whenever patients presented with a cardiogenic shock with an MI at 30 days. Then at 6 months, they showed that it's positive. So things can evolve and change, and here we can see that there's an evolution of things. Now, looking at the NOTION trial, which is basically the longest data that we have on TAVI, it shows that there's no significant difference between all-cause mortality at 10 years. Granted, this is done in Europe. It's using the CoreValve platform. And there's also data from the RIA trial, which is also in women. Now, focusing at the immediate post-procedural outcomes. I mean, it's very easy to say that there's less AFib in the TAVI population, there's less strokes, there's less bleeding, there's definitely more permanent pacemaker, but looking at that, there are several types of TAVI devices that we put in, and we know that the balloon expanding has way less permanent pacemaker, which is about 5 to 6% versus the self-expanding that has about 10 to 15%. So deciding what type of TAVI also can determine your risks in post-procedural. And finally, there's not a lot of moderate to severe PVL compared to surgical aortic valve. Now, in the mild PVL, definitely there's more mild PVL in the TAVR population than in the surgical aortic valve. Now, we shift gears into valve durability, and that's predominantly seen here by the recent publication of the Evolute Low Risk, where they demonstrated that Evolute valves in this population at 6 and 7 years started having more reinterventions. Now, saying this, the mechanism of failure was aortic regurgitation. And if you split those and understand the data a little bit better, these patients had, a lot of them had a significant post-dilation. And at that time, before 2020, people were using post-dilation based on the, not on the, following the IFU. So they were using sizes of balloons that were most likely more or larger than what is the waist of the valve and causing more harm to the valve. Now, saying this is a plausible reason, but it needs to be confirmed. Now, how about shifting gears to the trifecta valve? Well, the trifecta valve failed. It was off-market, and nobody said that surgical aortic valve replacement is bad, right? It's the valve at that time that was really bad. So despite that these patients failed, SAVR is still an option. So the valve failed, but the procedure did not fail. So, so shifting to the 7-year partner data, there's not much difference in reintervention. And then the NOCHEN trial, actually TAVR had better outcomes in terms of in valvular degeneration. So less valvular degeneration in the TAVI arm. So how about hemodynamics? Young patients, they want to be active, they want to really do a lot, and they really need something to give them that. For the SAPIEN platform, which is the balloon expanding, there was not much difference between the surgical aortic valves that have been used in the study, in the partner study, compared to the TAVR valves. On the other hand, the Evolute has shown significant larger EOA, basically larger areas, and then bigger areas typically have better performances in terms of hemodynamics. How about quality of life? As you can tell, of course, post-surgery, patients are not really active in the first month, so their quality of life always gets a hit. Versus the TAVR arm, there's definitely a better recovery. They can just be discharged the next day, and a week they can do whatever they want. So there's always that discrepancy or that difference in the first month. Then later on, at 6 months and at 12 months, things become the same. Quality of life becomes similar. So patients have to understand that recovery is also way quicker in TAVI. Coronary access. So a lot of people say that, oh, if you put a tall frame, you cannot really engage the coronaries. With surgery, we can see everything. Well, that's not the case. So seeing this, this is the ALIGN trial that was focused on balloon expanding data. And if you look there, SAPIEN, it's really easy to engage. Compared to the other Evolute or supraannular, there has to be a certain way that the valve is positioned where there is coronary alignment, and when there is coronary alignment, then you have better engagement of the coronaries. With the Evolute FX Plus platform, it has a coronary window that is 4 times the cells, and it was designed basically to have better coronary access. So saying this, there are new ways and new technologies focusing on this in order to expand the way that you can engage a coronary and do the procedures of the percutaneous coronary interventions. Redo TAVR. So for young patients, we want to really understand, can we put another valve through the groin or through a percutaneous access for these patients? Well, yes, we can, but it's a little bit more challenging than putting a TAVR valve inside a surgical aortic valve because there are certain things that we have to understand, and it's definitely patient by patient that we have to really trigger. So there are several ways or platforms that we can look into. You have a short valve, so those are 4 types of redo TAVRs that someone will have to deal with. Whether you put a short and short, a short and tall, a tall and tall, and a tall and short. And what's really important, when the first valve is short, it's really easy to know where's the line of the new neoskirt. And the new neoskirt is where you pin those leaflets up, and that line should not really block a coronary. So that's the main concept. But more importantly, which is more challenging, is if you already have a tall frame and you're putting a short frame, you have to really understand the anatomy very well. And probably for a surgeon, it's easy to explant. For a transcatheter, for a percutaneous interventionalist and a surgeon who's doing TAVRs as well, it's really important to understand these levels, where the nodes are, where the top of the commissures are, because that's going to determine what we call the neoskirt. Now, if you can look clearly here, in the tall frame, for example, an evolute, typically the node 6, and if you count from the lower bottom is the node 0. The node 6 is the upper frame of the commissures, and that's your new neoskirt, except for the 23 valve, which is actually at node 5. So that's number one thing. Number two is you delineate your level of the coronaries and the bottom of those level of the coronaries. Like you can see here on the left coronary artery, that's the lower bottom here, which is probably about node 2. On the right side, the RCA, it's probably around node 5. So, and the difference between the neoskirt plane and the lower bottom of the coronary is what we call the coronary risk zone. And if you want to implant a new valve, you want to implant the upper portion of your balloon expanding valve below the coronary risk zone in a safe manner. So sometimes it's very easy and you can do that. And you want to maintain a valve to aorta or VTA more than 4. So whether it's more than 4, it's very easy and it's safe. If it's between 2 and 4, then you have to think about other stuff. If it's less than 2, you cannot redo TAVR. So it's very important for the interventionalist, the surgeon in the beginning, and the interventional cardiologist to work together to understand whether the anatomy in the beginning is favorable for a redo TAVR in such population, assuming the life expectancy. And in between, you really have to understand and learn what kind of leaflet modification techniques and learn them, because that's going to help you put new valves inside. Now, TAVR explant. The old data is saying that those patients have really high mortality, and these patients were, like Dr. Ramlawi said, those patients were sicker, older, and they basically, part of them had also infective endocarditis, so they had very high mortalities. Now, this data is actually from our institution here, where there has been a significant proportion of improvement in procedural outcomes of TAVR explant. So before 2022, there were 27 patients, and their mortality at that time was 29.6%, versus from 2023 till 2025, there has been about 30 patients, and it's only 3.3%. So there's significant improvement in surgical explant by understanding how to remove the valve without harming other stuff, and understanding anatomy more. So the procedure is still safe, and thinking about it, that means if you implanted a TAVR and you think that the surgical risk is still reasonable later on, then you can still explant it at that time, and that might favor sometimes putting TAVR first in some patients. Now, the guidelines and current situations. The European guidelines have just recently published their update, and they shifted the TAVR population basically to the age of 70 and above, from 75. Previously, they used to say above 75, we want to do TAVR, versus the US guidelines, it's above 65, you can do TAVR. On the other hand, in the United States, as also Dr. Ramlawi showed, that there's a big population that is receiving TAVR despite their young age. So here, patients who were less than 65 years of age, still 47% of them underwent a TAVR, which definitely nobody's pushing for that, but that has been the reality. And we have to deal with that TAVR first approach, because you cannot control what other surgeons or interventional cardiologists are putting in different places. And that approach, if it's there, you have to deal with the consequences, whether a surgeon has to learn a TAVR explant or whether to do a TAVR and TAVR, all of those we have to learn. So the future things that are really important. If you're doing a TAVR first, which we're, as interventional cardiologists are interested in, there are really important things to know. Learn the new techniques. So cusp overlap technique for a self-expanding valve is very important, because it can decrease your permanent pacemaker placement by really landing your valve high. Also, it can help you with coronary alignment for coronary access, especially in young patients, and it can help in future TAV and TAV. For self-expanding, balloon expansion is very important, and in certain anatomies, you really need to do the double tap, basically do a post-dilation with the same balloon. And finally, if you're using a self-expanding platform, then use the IFU accurate sizing so you do not cause any damage to the leaflets. Now, there are so many new techniques that will open up the field and will push for a TAVR first approach. And these are some of them, and we can really imagine more and more and more. One of them is the basilica, where we can slice the leaflets in front of the coronary. This way, when you put a new valve, this spliced leaflet is going to open up like a V shape and not really obstruct the coronaries. On the other hand, a unicorn is an easier technically easier procedure that still needs to be proven as a safe approach, as all of this have been sort of case series and case reports. But basically, you slice the leaflet using a balloon and you sort of open it. And there are two ways of doing things. One is lacerate the whole leaflet, which we don't know if it's really safe. The other one is to intra-annular deployment, where you create a hole and you deploy the new valve inside the leaflet. And once it's opening, it's actually splitting the leaflet. And finally, the vector study, the vector procedure, which has been only in one case report that has been done recently. It's a very challenging approach to sort of create a graft or just percutaneously link the aorta to the left main or to the vessel by really advanced techniques. Now, saying this, that case was for 9 hours. They had to put the patient on ECMO, but you can really easily imagine that in the near future, people are just going to focus on this and going to make it better, improved, and going to create new devices that will facilitate that. So all of those will help in the future to think about, yes, if I place a TAVR first, then I can do another one of these procedures and help with another TAVR if my patient deals with it. If coronary access is an issue, maybe I will remove the whole leaflets and put a new device in, or even create a new graft percutaneously, despite that I've done TAVR first.
Having angina, just having you even imagine that.
I have some nitro patches in my pocket.
I'm actually not opposed to it, because all the high-risk patients will stuff it on cardiology now. Yeah, go do your vectors on them. Yeah.
I love it. So finally, TAVR in younger patients, it's a safer procedure in the short term, there's no question. I mean, we know that outcomes are sort of better in the first few weeks after this procedure. There's less risk of stroke, which is very important for young patients, especially disabling strokes. Risk of long-term AFib, there's no question that surgical aortic valve replacement is associated with higher burden of atrial fibrillation, but definitely TAVR has a little bit more increased of permanent pacemakers. There are better hemodynamics with self-expanding, and especially in these populations, yes, you want more hemodynamics, they want to be active. Valve durability is still reasonable to date. We don't really have really bad science telling us that, surgical aortic valves are way better than transcatheter heart valves. Coronary access is definitely feasible. It's way easier in the shorter platforms and a little bit more challenging in the longer platforms, but it's definitely feasible. And redo TAVR is feasible, and we're waiting for the RESTORE study that is ongoing, and we're very happy to be part of it. And finally, there's significant improved outcomes of TAVR explant. So if somebody had a TAVR first, you guys are so good that you can explant it in a very experienced centers and make it easy without really bad outcomes, like Dr. Atkins' 3.3 mortality in the last 2 years, amazing. And finally, there are new techniques and technologies that will prove that doing TAVR first is going to be okay, because you will have new techniques to implant new valves, new techniques to preserve your coronary access. Great. So thank you so much, and I'll have my opponent on the podium to debate that.
Well, thank you very much, everyone, for staying so late. I am the last thing between you and the weekend, so I will try and make this painless, I mean. If they can find my slides.
No, but you did a great job, though. Yes, indeed.
Usually it's the other way around. We're speaking to cardiologists. So. Payback is hell. All right, let's move along here. All right, so I do have some disclosures. I'm an aortic surgeon with a focus on aortic and root surgery. I am part of the structural heart team here. I am an investigator for the various companies you can see here for clinical trials for TAVR, and just like every surgeon, I'm opinionated and biased. So when Ziad first asked me to participate in this debate, I said I have the easiest job in the world. You want me to convince a room full of surgeons that surgery is the best first option. I'll take that task any day. So TAVR first versus SAVR first. So we all agree that in patients greater than 80, TAVR first strategy, that's the way to go. As long as they have a life expectancy of greater than a year, they're not a cohort C patient, somebody that should not have anything done. In patients less than 65, a Ross or a mechanical valve is best if there's no contraindication to vitamin K agonist or warfarin. In the 65 to 79-year-old age, that's where we run into the conundrum here, where you have to have the decision of TAVR versus SAVR, and that really should be based upon the patient's anatomy, the patient's physiologic risk, and patient preference. So in patients undergoing bioprosthetic valve replacement, either TAVR or SAVR, if they live long enough, they're likely to need at least one other operation in their lifetime, possibly even a third. The lifetime management of aortic valve disease becomes very important in those that have a life expectancy greater than 10 to 20 years. And so we have to have a well thought out management strategy for these patients, not for the short term, but for the long term. So I'll skip through the guidelines, but again, basically in the US guidelines, less than 65, they should have a mechanical valve. 65 to 70 can be either. Greater than 80, TAVI first should be the strategy. The latest set of European guidelines, as the others suggested, dropped from 75 down to 70. Greater than 70, a recommendation for TAVR. Below the age of 70, SAVR is recommended. Okay, this thing's not working. All right. So again, each of the procedures has their own strengths. SAVR, much lower paravalvular leak, less risk of pacemaker. TAVR, less AFib, bleeding, kidney injury, hospital stay, time to recovery. And at least data-wise, surgery has better durability and coronary reaccess, if that's an issue. So to answer the questions of which procedure patients should have first, we have to answer the following questions. What patient populations were tested in the randomized trials? What size valve will the patient get, and what is their risk of patient prosthesis mismatch? And I really think that's probably one of the most important questions to answer. What's the durability of TAVR in low-risk patients? What's the durability of SAVR? What's the risk of redo SAVR? What's the risk of TAVR explant? And what's the likelihood after SAVR that a valve-in-valve TAVR can be done? And the last question is, what's the likelihood after TAVR that a redo TAVR can be done? And some of these are questions that we have answers for. Some of these are questions that we're still learning. So the patient populations tested. So again, like we've all discussed here, mean age in the PARTNER trial, 73. In the Evolute trial, 74. 7% were less than 65 years of age. 6-7% in either trial were less than 65. 1.3% were less than the age of 60. A third of patients were female. Bicuspid valves were not supposed to be included in either one of these studies. They had a couple that were in there. But these are patient populations that were not tested. So what size valve would the patient get, and what's the risk of patient prosthesis mismatch? I think as surgeons, we probably should not be implanting 19 and 21 millimeter valves in the vast majority of patients due to the risk of patient prosthesis mismatch. As cardiologists and surgeons, we likely shouldn't be implanting a 20 millimeter Edwards sapien valve. If a small annulus, and that's defined as an area less than 430 millimeters squared by area, or if you think you're going to have to implant a 19 or 21 millimeter valve, and the patient's a reasonable surgical candidate, best to do a surgical aortic valve replacement with a root enlargement and get that patient a larger valve that has better durability and hemodynamics. In the PARTNER low-risk data, again, as the others have alluded to, no real difference so far out at 7 years, and this just came out last month. If you look, however, at the Evolute low-risk trial, there's some concern, an early signal that there's a much higher rate of aortic regurgitation starting at years 6 and 7. The Evolute folks would argue that There was not great guidance in the original core valve devices and Evolut R about ballooning afterwards, and I think in 2020 or so they came out with size recommendations of the maximal size balloon that you should have to post-dilate these valves, and we think that maybe that's causing injury to the leaflets and leading to some of this AI and structural valve degeneration. But when they've gone back and they've looked, not everybody had post-balloon dilatation of the valve. So it's not entirely clear why some of these valves are developing severe AI. It's not totally related to just ballooning. And so, again, no composite difference between the major endpoints. However, reintervention, especially in the setting of AI, is significantly increasing in TAVR in the Evolut valve. So this is a patient of mine. This is a 66-year-old who underwent TAVR with a 34 Evolut R as part of the bicuspid study. It was post-dilated to 25 millimeters, and the IFU only suggested a year later that it should only go up to a 24 balloon. He presented with acute severe AI decompensated heart failure. You can see the valve leaflet torn there. There's really no structural valve degeneration or calcium buildup and narrowing of the valve. Literally, it's just torn off the commissure. He underwent TAVR explant. We were able to get a 27 Edwards Inspirus bioprosthetic valve in there, and he should be good for valve-in-valve TAVR if needed in the future. When I pulled the commissure over on this other side here, there's another hole that's started that you can see there. So what's the durability of SAVR? This is a recent paper looking at reoperation in bioprosthetic versus mechanical valves. This is one of the largest studies, 140,000 patients between biological and mechanical valves. Again, 10 years after SAVR, low rates of reintervention in the mechanical valves, and then you can see the rates of reintervention there on F, there on the right-hand side. The younger you are, the shorter the bioprosthetic valve is going to last. But overall, very good durability. This is the Medtronic Avalis valve in the Paragon study that came out. They have 7-year data, 94% freedom from all reintervention, 99% freedom from structural valve degeneration at 7 years. The Edwards Inspirus valve, the Commence trial, and so these are contemporary valves that people are using. Again, they have 7.7-year data, 99.3% avoidance of reoperation, very durable valves. And they'll follow these valves out for a significant period of time. What's the risk of redo SAVR? This is a paper that was presented at the STS, a J. Maxwell Chamberlain Memorial paper, redo surgical AVR versus valve-in-valve TAVR, replacement for degenerated bioprosthetic valves, and surgery wins. As you can see here, survival analysis. The risk of redo SAVR in general is low. Again, some of these are probably some biased choosing of patients. What's the risk of TAVR explant? We've talked a little bit about that. The risks are very high here. Again, some of these series are confounded by high acuity presentations, endocarditis, concomitant procedures, which happen in about 50% of most of the studies here that have looked at TAVR explants. They definitely have longer cross-clamp times and cardiopulmonary bypass times. Surgeon inexperienced with this procedure, but as we continue to do more and more of these, our mortality rates will continue to go down. So what's happening in the real world? Everybody's kind of alluded to this. I'll go to the next slide here. If you look at the far left there in the red box, TAVR less than 65 years of age in almost half of patients in the US, which is not supported by the guidelines, and associated with a 2.5-fold increase in mortality risk. Again, you can see there less than 65 years of age, 6 and 7% of the populations in the low-risk trials. So our approach, all patients should have a cardiac-gated TAVR CTA to evaluate their anatomy prior to recommending the treatment plan. We do use 3D planning software to model both TAVR and SAVR valves, and the possibility of TAVR in the future. These days, I don't really think a surgeon should be going into the operating room and trying to just only rely upon the sizers about what size valve you're going to get in, or even the preoperative or intraoperative transesophageal echo. I want to go in there with knowing how big the root is, knowing that I'm going to have to do a root enlargement, have spoken with that patient beforehand, and have a plan going into the operating room of exactly what I'm going to have to do, all based on the preoperative imaging. All these patients are seen in our multidisciplinary clinic and given both options. Anybody with a small annulus, or if you can only put a 19 or 21 valve in, they should get a SAVR with a root enlargement. Or if their coronaries are very low, you may want to also consider doing a root replacement and elevating the coronaries, setting them up for a future valve and valve TAVR. Bicuspid valves, especially if they have a very heavily calcified raphe, really should undergo SAVR. And in those with small annuli, low coronaries, better to do a root replacement like we just spoke about. And in bicuspid valves, their risk is much, much higher risk of mortality and root rupture if they have a very heavily calcified raphe. Anybody with an ascending aneurysm and bicuspid aortopathy and they're low risk, it's better to do surgery and an ascending replacement. So again, less than 60, we're doing a Ross or mechanical valve, 60 to 70 bioprosthetic SAVR, 70 to 80 TAVR versus SAVR based upon their anatomy and preference, and greater than 80, they should undergo a TAVR. So as we discuss, when I see patients, I say to them, you know, if you had to have open heart surgery, would you rather have it now when you are young, healthy, and low risk, or when you're 10 years older with more comorbidities and maybe the possibility of being frailer? That kind of resonates with them. If it's a first-time SAVR, likely can be done through minimally invasive approaches, as we've discussed throughout this meeting. You're likely going to have to do TAVR explant done through a full sternotomy. Has anybody else done TAVR explant through right anterior thoracotomy or a minimally invasive incision yet?
Yeah,
A couple folks.
Vinay Bagwa did publish a paper that they did a robotic.
I saw that.
Yes, TAVR explant. That's the one I'm aware of.
Right. So the results are in, SAVR for the win. Sorry, Joe. All right. Thank you very much, everyone, for joining me.